The next panel is fun for me because it's a bit of friends and family, and these are truly experts for our root cause. I think somebody earlier appropriately said this is an iatrogenic epidemic. And what that means is that providers created this epidemic, prescribing created this epidemic. And I know there's a number of narratives out there about how this is no longer a prescribing epidemic. I agree, it's not purely a prescribing epidemic, but at its origin, this is about prescribing. And so we're going to talk about prescribing all the way from acute care to chronic pain to primary care, and we'll even touch on medication-assisted therapy. So our panel is entitled Health System Approaches to Opioid Prescribing. We have 4 speakers with us. Mike Englesbe is the Cyrenus G. Darling, MD, and Cyrenus G. Darling, Jr., MD, professor of surgery at the University of Michigan in the section of transplant surgery. He practices liver transplant in both children and adults. He is the director of the Blue Cross Blue Shield of Michigan Value Collaborative, Michigan Surgical Quality Collaborative, one of the largest general surgery, gynecologic surgery, and vascular surgery collaboratives in the country. His research is concerned with the relationship between cost and quality of surgical care, and has also specifically worked on frailty, surgical outcomes, post-operative opioid utilization, and morphomics, the analysis of the human body factors derived from medical imaging to understanding how variations impact and predict risk models. So I'll introduce everybody, but please join me in welcoming Dr. Englesbe. The next speaker will be Dr. Clauw. He's a rheumatologist and an internationally recognized pain researcher. He's the founding director of the Chronic Pain and Fatigue Research Center. For some of you who may not know, this is really a leading center for pain research for all types of pain. He mentors many people across the clinical and translational research domain for pain, and he wants to understand how to better diagnose pain. He has held several institutional leadership positions here at Michigan, including he was the first associate dean for clinical and translational research and was the first PI of our CTSA, our MSHR, Michigan Institute for Clinical and Health Research, and brought that to the University of Michigan. He received both his undergraduate and his medical degrees from the University of Michigan, and did his internal medicine residency at Georgetown, where he eventually held roles as the chief of rheumatology and the vice chair of medicine. Please welcome Dr. Clauw. Michael Barnett is here today from Harvard University. He is an assistant professor of health policy and management at the Harvard T.H. Chan School of Public Health, our primary connection for today's event. And he's a primary care physician at the Brigham and Women's Hospital. Dr. Barnett received his MD from Harvard Medical School and completed residency and fellowship in primary care and general internal medicine at the Brigham and Women's Hospital. Dr. Barnett's research focuses on the understanding and improving the healthcare delivery system with specific interest in the role of physicians in the opioid epidemic as prescribers and as providers for opioid use disorder treatment. He has received a number of Best Research Awards, including a research award from Society of General Internal Medicine and Academy Health. Please welcome Dr. Barnett. Our last speaker today is Dr. Amy Bohnert. Dr. Bonnet is a mental health services researcher with training in public health, which focuses on the research and epidemiology of brief interventions regarding substance use and related disorders. Within a team of collaborators at the University of Michigan and the Department of Veterans Affairs, she's led a number of projects related to overdose and prescription drug safety. A number of her research activities have been aimed at improving care during substance use disorder treatment settings. Dr. Barnett has demonstrated particular expertise in applying epidemiology methods to the analysis of electronic health records based on data to answer important questions in healthcare service delivery. Dr. Barnett earned her Ph.D. in public health at Johns Hopkins University and completed a postdoctoral fellowship with the Department of Veterans Affairs National Serious Mental Illness Treatment Research Center and the Evaluation Center in Ann Arbor, Michigan. Please welcome Dr. Bohnert. So to start our session today, we have Dr. Englesbe.
Great, thank you. It's an absolute honor to be here. I want to thank the organizers for the opportunity to speak. Like many of the previous speakers, I have deep ties to Harvard. I've been rejected by Harvard numerous times over the course of my academic career. Maybe as I get older, we'll have to see. So my day job is I do liver transplants, and I got interested in this problem about 5 years ago. So if you're a transplant surgeon, there's kind of two parts to the job. You go and get the organs, or you put them in. And I was on donor call, and I was sent out to do a donor. It turns out we had 3 in a row, and it was about a 36-hour period where he just kind of was flying all around the state of Michigan, procuring organs, bringing them back for my partner, and helping them put them in. It was exhausting. The first donor was a young woman. I think she was 20, and she had had a sports injury in high school, got hooked on opioids and overdosed. The second donor was almost exactly the same story: wisdom tooth extraction, opioid exposure, overdose. And then the third young woman, who I'll never forget, was a high school graduation party and experimented with opioids and alcohol and overdosed. And simultaneous with this kind of weekend, there's a new policy in our region where we would have this moment where the family would read these stories. And as a transplant surgeon, we have a lot of Teflon on, and like any nurse or doctor probably, and there's never really, this is a new thing where we would have to stand there, silence in the room, they'd even turn off the beeps, and they would read some kind of story from the family about the donor's journey and the gift. And so I got to kind of hear the stories of these donors for the first time, and it obviously affected me greatly. So my response was manyfold, one of which was to talk to Barb McQuaid at a soccer game and ask her kind of what's going on with opioids in the area. And then probably the most fruitful thing in my professional career is I talked to Chad Brummett and Jen Walge, and I knew they were starting to do some work on this kind of nascent epidemic, and I asked to be involved. And we started kind of focusing on the care of patients who show up for surgical care on chronic opioids, and anyone who does medicine knows that these patients are very hard to care for. We worked on that for about a year without much success, and I remember at some point Chad kind of looked at Jen and I and said, addiction, opioid use disorder, these things are really complicated, and you guys are surgeons, let's take another approach. That's him making fun of me, which is kind of how the relationship has been for 5 years. But he then said something I think that really turned our strategy significantly. He said, why don't we focus on keeping healthy people healthy? So this is the conceptual model that we think we can impact on the opioid epidemic as acute providers, emergency room doctors, dentists, and surgeons. The vast majority of people who move on to substance use disorder or addiction get their first exposure from opioids from a surgeon or a dentist. And we started to look into this problem deeply, and we found out a couple things. Most patients who are given prescriptions who have chronic pain take all their pills, but if you get a prescription from a dentist or a surgeon for normal routine surgical care, you tend to have a lot of leftover pills. So who's ever had a procedure and had leftover pills from a surgeon or a dentist? Yeah, the vast majority of the people in the audience. And this fuels the opioid epidemic, obviously. But we learned, I think, even more concerningly that the 6% of patients who are well, who come in not on opioids, who have routine surgical care, leave the event as new chronic opioid users. To put that in context, if I took out everyone's gallbladder, there's 400 people in the room, whatever 6% of 400 is. I didn't get into Harvard, so I'm not sure I can do it. It's 24. 24 of you would then be left as a chronic opioid user, which is a devastating number. That's like those two tables over there. And some of those patients would then move on to substance use disorder and potentially overdose. So, and that number is relevant kind of for all types of surgical care. So particularly disturbing is women who have bad breast cancer, mastectomy, systemic therapy, reconstruction, survive the cancer. Almost 20% of those women become new chronic opioid users after that horrible journey. And then among adolescents who get routine surgical care, about 5% of these young people become new chronic opioid users. I think that's a devastating statistic and certainly underscores kind of how we as dentists and surgeons are involved in this epidemic. Essentially comes down to overprescribing. So just like what we saw here, when you have a problem, recruit your most talented people. We recruited a medical student, and he came up with a really cool experiment I'm going to explain to you. We looked at everyone at our institution who had a laparoscopic cholecystectomy, and these are routine operations, one of the most common operations done in the United States. And he called all the patients, and he knew how many opioids we had given them. That was 45. He asked them how many they took. That was 6. This is all the leftover pills. Then he made a little video, and he distributed it to all the surgeons, and our boss endorsed it and said, hey guys, you're giving 45 patients retaining 6. Why don't you try 15 and see how it goes? And we did that, and the beautiful thing about surgical trainees, if you tell them what to do, they like no one got 16, no one got 14. Like as of that day, everyone got 15. And what happened is patients took, instead of 6, they were taking 3 pills. And their pain care was no different. They weren't calling for more refills. The kind of world didn't end. And this conceptual model, the small experiment that we did within our own institution, became the framework for how we've partnered with Michigan Department of Health and Human Services, Blue Cross and Blue Shield of Michigan, and formed what we call M-Open to really drive best practices and evidence-based prescribing for surgical care in the state of Michigan. So these are our recommendations. These are based on data flows from all the hospitals in the state. We know how many pills people get. We know how many they take. And we suggest how many should be prescribed. And we've been very effective, and I'll show you the data in a second. So on the top left, laparoscopic cholecystectomy, it's 10 pills. If you've ever had a procedure, look at what we suggest and think about how many pills you were given, and I think you'll find it's much less. Little anecdote on the bottom right, you'll see 0 for dental care. I had a root canal on Monday. It was awesome, and I was thinking about this problem as they're kind of drilling into my cerebellum. And after I finished, I asked the endodontist, if he was going to give me any opioids. And he said, no, I saw some talk up from some guy, and I'm not supposed to give any more. And I was like, so this is data from the state of Michigan. Chad, Jen, and I started talking about this among the acute care providers, anesthesiologists, surgeons, in February 2017. We were having a little bit of progress. This is the number of pills. The average surgical case got about 30 pills. This is kind of all types of surgery. And then we released our guidelines in, I think, about October 2017, and the numbers came down. And this data is a year old. At the end of it's May 2018. But the bottom line is we used to give 30 pills. We now give 15, and that's good for the public health in the state of Michigan. Most importantly, we're nurses and doctors doing this. So patient satisfaction actually improved a little bit, and overall pain scores didn't change. So we were able to give excellent pain care and right-sized prescribing. And I think that is one strategy to combat the opioid epidemic. It's a small part of a really complicated problem, but I think, or I'm optimistic that when we think about it, the average American has 9 procedures over the course of their life. So each of us, on average, will have 9 procedures. If we have a 6% risk of new chronic opioid use after all those procedures, certainly this is fueling some component, if not a large component, of chronic opioid use, misuse, and addiction. And I'm optimistic the next time I have to do 3 donors in a row, at least in the state of Michigan, it's unlikely the 3 of them are going to be overdose patients. Thank you very much. I'd like to introduce my friend, Dan Clauw.
So I'm going to come at this from a little bit different standpoint, and that is from the perspective of someone that researches and cares individuals with chronic pain. I want to read a quote, though, first from one of the earlier speakers, talking about the drug cartels. The cartels are relentless, they have no respect for human life, and they are motivated by money. Well, I'm going to actually expand a little bit on what Dr. Rosenthal talked about earlier today about the role of the pharmaceutical industries in creating the opioid epidemic. And I, like her, am testifying against opioid manufacturers in ongoing litigation. And one of the coolest things that's happened to me in the last couple of months was mid-deposition in the state of Oklahoma. 2 hours into my deposition, the lawyer for Purdue walked out of the meeting, and 3 hours later they had announced that Purdue had settled for $270 million just for the 600,000 people in the state of Oklahoma. So these opioid settlements will be large, and I'll end by talking about the opportunities we have to use that money in a useful way to treat individuals that have been harmed by this epidemic. But I want to go back to how this all started with OxyContin. One of the advantages of being old is I was trained in an era where it wasn't okay to use opioids to treat chronic pain. That was actually the way that it always was, literally until the mid-1990s. When I was trained, we were taught that opioids should not be used to treat chronic pain, and that is largely the way all other countries other than the United States still view the use of opioids in the context of chronic non-cancer pain. But it turned out that in 1997, without any additional data, no studies suggesting that OxyContin was effective for chronic pain, the FDA, in a single closed-door meeting, changed the label for OxyContin. And this opened the floodgates. Because what happened then is that all of the other opioid manufacturers, if you've had the opportunity to work with the FDA, and I have, and I actually like the FDA, one of the things that they do is they really depend on regulatory precedent, and they're really worried about getting sued by pharmaceutical companies that if they didn't give the same guidance to one that they gave to another. The fact that they allowed the OxyContin label to be modified to treat chronic pain led to almost all other opioid labels being subsequently modified, again, with no data or evidence suggesting that opioids actually work to treat chronic pain. So the other opioid manufacturers wanted in, and they got in. They were incredibly effective at co-opting academic thought leaders, many of whom have been named as parties to these lawsuits that went around the country, got large amounts of money to be on speakers' bureaus, and told physicians that opioids were effective to treat chronic pain and safe to treat chronic pain. The drug distributors and pharmacies knew exactly what was going on. They knew about these drug mills and everything like that, but they were making a lot of money, and they weren't doing anything to stop this. They even co-opted a lot of our professional organizations. We heard a little bit earlier, but I want to expand upon that. Purdue and the other pharmaceutical companies provided educational grants to JCAHO, to the VA, to fund the conferences that led to the fifth vital sign. They provided educational grants to all these tiny little mom and pop advocacy groups, pain advocacy groups that were struggling because they only had a single member, and then they were getting hundreds of thousands of dollars a year, and guess what their message was to physicians and other providers? That opioids are effective to treat chronic pain, and they're safe to treat chronic pain. So and when you get involved in litigation, you actually can see internal documents from companies like Purdue, and it is maddening. They are evil. They are no less of a cartel than the traffickers on the streets. And the FDA, again, is continuing to approve opioids. Just within the last couple of months, they're continuing to approve incredibly potent, more potent opioids, even though many of us are saying, what is going on here? This is a 22-year experiment that we know the result of now, and yet we're continuing to have the label say that opioids can and should be used to treat chronic pain. So where are we now? It turns out there's millions of chronic pain patients on opioids. Very few of them are getting significant benefit, and this comes at significant risk. The data I like talking to people about is all-cause mortality in individuals with chronic pain that are taking an opioid is 30 to 70% higher in any given year than if they weren't taking an opioid. Now think about that. You have to do a lot of bad stuff to increase your risk of dying in any subsequent year by 30 to 70%. And this is what just being on those drugs, a chronic pain patient being on those drugs. And I think we're really underestimating the deaths from opioids because we don't count those individuals with chronic pain that are dying at these excess rates of suicide, of motor vehicle accidents, of overdoses, of falls, of all sorts of different things. These are incredibly dangerous drugs to give individuals with chronic pain, but again, with really no evidence that they actually are effective or working in the setting of chronic pain. And one of the things that really makes my head explode is when the narrative is driven by these anecdotes, by these patients that are brought up before the FDA, or they're brought up before our Health and Human Services Pain Management Task Force, that say that they're on high doses of opioids and they're doing incredibly well, and they need their opioids. And those anecdotes are really driving, in many cases, our continued use of opioids rather than data or evidence that we should be using instead. And I get in a lot of trouble for doing this. But I talk about those individuals that are on very high dosages of opioids that are doing really well. I say these are like unicorns. I've heard about them, but I've never seen them. Because it literally is the case that these are really rare individuals. I don't do much clinical care anymore, but I talk a lot to people managing a lot of chronic pain. And I haven't talked to any providers that would say that they know of more than 5 to 10 people total that they've seen throughout their entire career that are really doing well with chronic pain on high-dose opioids. And so we have to really refocus our efforts now on what can or should be done, not what was done. And I think one of the things, I'm really proud of what will come out in the next couple of weeks. We just voted yesterday on the M.H.S. Pain Management Task Force document. We're not allowed to distribute it yet until it gets distributed by Health and Human Services. But I think it'll be an incredible roadmap for our health systems, for our providers, because we spent a lot of time thinking about how all the government agencies and really any payers, providers, really have to sort of rethink the opioid problem. And I think we will have an opportunity, whether it's in Michigan Medicine and Harvard, to create demonstration projects and really show that if we manage chronic pain the way that it should be managed, one of the big things that will come out in this M.H.S. task force document will be that payers have to start reimbursing for the non-pharmacologic therapies that really should be the bedrock of the management. Of chronic pain, and we can't really put these programs into place unless and until reimbursement changes and that these things are reimbursed. But if you want to look for a model to aspire to, that the VA and the DoD models for taking care of individuals with chronic pain right now is that in primary care, the primary care physicians are wrapped with behavioral medicine specialists in primary care, and they also have access to all these non-pharmacologic therapies, chiropractic manipulation, acupuncture, yoga, Tai Chi, all of these things that I couldn't imagine 30 or so years ago when I was trained in medical school that I would be up saying that the evidence base for these therapies is really much greater than the evidence base for a lot of the things that we use much more often and that are a lot more expensive in the care of chronic pain. So I'm inherently an optimist. I think actually we have an incredible opportunity because of what happened with opioids and pain, that this is now giving attention to the pain field, and I think it will rapidly lead to changes in reimbursement and changes in care models that'll lead to improvements in pain care in the future. Thank you. And Michael will be next.
All right, thank you. It's such a pleasure to be a part of this amazing panel, and I'm looking forward to the discussion. And before I launch in, I just can't resist mentioning that in a former life, I was a professional classical musician. I'm just completely in awe of the musical performance that we heard. And I also can't imagine having the courage to have your life set to song. So I would like to change gears now, and I think it fits in well with the prior talks, which is thinking about the amazingly difficult policy challenge of what happens to the millions of patients who are now in chronic opioid therapy. And before I go on, I'll just also make a disclosure that I'm also an expert witness in ongoing litigation against opioid manufacturers. So let's see here. All right. So we've heard today there are hundreds and hundreds of laws being passed restricting opioid prescribing. And there's an increasingly hostile environment for opioid prescribing in many areas. And as I've been watching this, I've also been seeing report after report in the media that has been really raising a lot of alarm about what is happening to patients on chronic opioid therapy as opioid prescribing plummets and we have a much more fearful environment around prescribing. There have been descriptions of things like patients being involuntarily tapered off of their opioid therapy, and things even as horrifying as reports of suicides after patients who are on chronic opioid therapy have been discontinued from their medication. Of course, this is all incredibly concerning. One challenge, though, is that we don't have any data on what is going on here at a population level. We can't really design policy unless we know what is the magnitude of what's going on and who is it affecting. So what I'd like to do today is walk you through a few preliminary results that we have that I think can be a jumping off point for a discussion that frames some of these policy questions. So first, the question I'd like to ask is, what are physicians doing when they stop patients on chronic opioid therapy these days? So the fastest possible speed recommended in expert guidelines to stop chronic opioid therapy is to decrease patients off of their opioid dose by no more than 50% every month. So we wanted to see how often were physicians actually fitting in with these guidelines. Anything faster is against guidelines, can trigger withdrawal, and at the very least be agonizing and potentially incredibly harmful for patients. So we used Medicare data, and we looked at patients who are on 12 or more months of chronic opioid therapy, so people who are on for really quite a while, who stopped opioids at any point in that 5-year period. And we were somewhat stunned to find that actually only a tiny minority of patients actually have their chronic opioid therapy stopped within guidelines. And in fact, if anything, the majority of patients have no taper at all. And it didn't matter whether you had a low, moderate, or high dose of opioids, still no taper was actually the dominant way that physicians stopped therapy. And this is, of course, quite contrary to expert consensus and could be the source of significant suffering. The next question I want to ask is, what happens to patients when chronic opioid therapy is discontinued? This is a pretty hot question right now. There's no question that it can be quite difficult for patients to have their therapy stopped, but it turns out to actually be a very hard question to study just because of the differences between people who stop therapy versus those who don't. We wanted to get some insight into this problem and avoid those methodological challenges by actually looking at an interesting question, which is, what happens to the family members of chronic opioid users who stop therapy? Is it possible that discontinuation is actually disruptive enough to prompt the family member of an opioid user to fill an opioid prescription themselves around the time of discontinuation? We looked at a decade of data from private insurance claims, and we looked at how often did family members fill their first-time opioid prescription when their loved one was stopped on therapy. And predictably, for individuals who are in the below the median of opioids in the population, when they were stopped from their therapy, we didn't see much going on. But it was a different story when you look at the top 10% of opioid users in this decade of data. And what we found was around the days of discontinuation, there was an enormous spike in the likelihood that a family member would have their very first opioid fill that we observed in this decade of data. To us, this is evidence that the health system could be profoundly failing at least some chronic opioid users to the extent that family members might actually have to step in to help their loved ones. And I think given the prior slide, the results that I presented, I think this is not actually an implausible explanation for what we're seeing. So I'd like to finish up by asking actually a pretty basic question, which is what is happening to the population of patients in the US on chronic opioid therapy? It turns out that there are, again, surprisingly little data on this, and it's also, you can look at it from many different angles. So if you'll humor me, I'll just use kind of a bathtub faucet analogy here to explain the different ways of looking at this issue. So first, we have the question of how many new users, new chronic users do we have entering the population? Again, we're using Medicare data here. And what we looked at was the number of people per 1,000 Medicare patients who were using opioids for 12 months or more. And consistent with what we've been seeing nationally, you can see that the rate has fallen actually quite a bit, 35–40% over this period. And then there's the other end, which is how many people are being stopped and actually coming down and actually coming out. We looked at the rate of the same type of opioid user actually stopping therapy at any point during this period, and we saw that actually it's increasing, maybe around somewhere between 20 and 30%. The thing is that actually neither of these, even though you would assume that the population of chronic opioid users is falling, neither of these actually tells you what's happening to the total pool. And surprisingly, what we found was that, if anything, the total number of people who are on 12 or more months of therapy at any point was actually, if anything, increasing a little bit. For us, what this means is that that despite the changes despite all the changes in the healthcare system, chronic opioid use is just as common as ever, and the challenge of how to design policy that can compassionately account for these patients, that problem is just as present as ever. So I have these 3 takeaway points from the results I just presented, and I'll just emphasize again, some of these are preliminary, so it's possible that they may shift over time. But what I'd like to discuss afterwards is how can we incorporate information like this into policy, and what research do we need to do to actually address maybe any questions you have after hearing about this, or to design policy that you think will be effective. And any policies that we design moving forward, I think, need to reconcile the competing factors implied by these findings, which is how can we encourage physicians to use chronic opioid therapy less and less, but also preserve its compassionate use for those who are either dependent on opioids or who still need it. Thank you very much, and I'm going to pass it on to Dr. Amy Bohnert.
Thanks. Good afternoon. I am going to talk about the CDC opioid prescribing guidelines. I want to answer a little bit the question here of whether they improve outcomes. I'm going to show some data on whether or not they change prescribing, but I'm hoping as a panel we can discuss the more provocative questions around whether they really improve patient outcomes and how to do policy that will balance some of the potential harms that have been alluded to over the course of the day. First, I want to acknowledge, it seems I'm missing a little slide here, that I was funded by the CDC in part to do this evaluation work, and have unrelated funding also from the CDC for other projects. So they had some input into the design and interpretation for the evaluation of the guideline that we did, but ultimately these are my ideas and I don't represent the views of the CDC. So before I get into what happened after the guidelines were released, I wanted to describe a little bit of what is in the guidelines, because they're maybe a little bit more controversial than I think they should be. The first couple set of guidelines are around when to start. So the ideas here are to try other treatments before opiates, other pain treatments, to set goals with the patient on what the goal of treatment will be, and to discuss the risks and potential benefits of treatment. The second set are on what to use when you're using opiates for chronic pain. So one is to start with short-acting rather than long-acting opiates. The next is to use the lowest effective dose. And this is perhaps the guideline that's been the most controversial, which was based on some analyses I did with my team and with colleagues at the CDC, specifically recommending to be cautious when escalating above 15 morphine equivalent milligrams, and to generally try and avoid going above 90 morphine equivalent milligrams at all. And you'll notice that that was about escalating and not about what to do with people who are already on those doses. The next is for acute pain, to generally use as few of day supply as necessary, and typically trying to limit below 7. And the last one in the how to use it is to reevaluate the risks and benefits as you go, and consider tapering using the recommendations that Dr. Barnett alluded to. The last set are on how to address harms. So assessing risks and prescribing naloxone when it's appropriate, reviewing the prescription drug monitoring program, doing a urine drug screen annually, avoiding co-prescribing benzodiazepines, and using medications for opioid use disorders when they're indicated. So I think all of that fits into a Post-it note. I think my colleagues who have treated chronic pain for years would probably say that everything I just described is common sense, self-evident, and based on things we have known pretty much forever about treating chronic pains with opiates. So in some ways, you'd expect with that there wouldn't be much of a difference to make by putting out guidelines that are so obvious. But we did and this is with with those colleagues at the CDC was published in Annals of Internal Medicine last fall. We used IQVIA data to look at national prescribing. This is data that comes from pharmacies when fills are released throughout the US to see how the prescribing trends may have been impacted by the release of the guideline in March 2016, which is that dotted line there. So what we found is that opiate prescribing was generally declining. This is overall opiate prescribing, so rates of prescriptions, any dose, any amount, was generally declining already before the CDC guideline was released. But after the guideline was released, the rate of decline speeds up a little bit. And in our statistical testing, that was significant. And you can see that by the way that the line decreases faster here. We also looked at prescriptions where the total amount in that prescription was for more than 90 morphine equivalent milligrams to go along with that recommendation around avoiding high doses. And similarly found that it was declining and appears to be declining at a faster rate prior to the guideline release. And again, that rate of decline speeds up after the guideline was released. Unfortunately, because this was a guideline that had national implications, we don't have a good comparison group to see if this is faster than you would expect if you were comparing it to somewhere during the same time period that was not in the scope of the guideline. But nonetheless, some evidence that potentially guidelines are one way to approach this problem. We looked at this in terms of looking at other risky prescribing. We looked at the benzodiazepine co-prescribing with opioids, which also declined over time and appears to decline faster after the guideline release. We looked at starting with a extended release opiate instead of a short acting for an opiate naive person. That actually was not impacted by the guideline, although that's a fairly rare practice because it is so obviously bad. So my takeaway points: opiate prescribing is declining. It's been, I think, as the harms of opiates have become known, providers were responding to that even without a guideline out there. But this guideline does appear to have changed prescriber behavior some in these specific metrics around prescribing. And that is despite the fact that the guideline itself did not have any inherent enforcement of those policies, although you'll notice that some of the national policies, or state policies rather, that were described in earlier presentations basically took these guidelines and turned them into laws. So there's been some specific regions where there is some actual enforcement. What I think it would be great to talk about it as a group and is where we need to go next in terms of thinking about what got used instead. So as opiate prescribing went down, is there any evidence that people actually got pain care in other ways that still addressed their pain? And if they didn't, what was the patient satisfaction? What was the pain management like? I think the open data on that's been really compelling, but we don't know the same outcomes for chronic pain. And then also, what has access to medication for opioid use disorders happened in the context of people whose opioid use was problematic and was noticed by their providers as they attempted to improve their prescribing? Are people really getting linked to care? We hear lots of anecdote of people who were abruptly tapered and their doctor said, sorry, I'm just not treating you anymore, and aren't given any kind of warm handoff to treatment and may just not have any access to evidence-based treatment for their opioid use disorder. I think that's very concerning. And honestly, sometimes people have told me anecdotes of doing this to patients as if they were proud that they were the good prescriber who knew to stop prescribing, and don't even necessarily realize that that's not good quality care and that that's putting their patient in harm. So I look forward to discussion on these with my colleagues. Thanks.
Great. Well, today we have a mixed audience. It's not a classic medical conference as most of you would speak at. So we're from policy to practice, and we've seen lots of policy come through, and I kind of wish I had Rebecca Haffagee back up here too, because she could probably add to this conversation as well. But policies come through many states, and we had a suite of policies come through the state of Michigan. One of my questions, and because I think it's coming from the audience, is what are the things that you would advise to policymakers and payers in terms of either policies or practice changes that payers could enact that we still need today as it relates to where we are with opioids and with pain? Anybody want to take that one on first? Is that too hard?
I guess I could start.
Okay.
So I guess my feeling is, we heard earlier today that opioid prescribing is actually down 50% from its peak in 2011-12. And we're not. It's not clear how much that decrease in prescribing has actually led to. Seems preliminarily like the overdose curve is actually kind of starting to flatten out and maybe decrease a little bit, which is actually a pretty amazing development. But my feeling is that policies that are kind of increasingly restricting prescribing beyond maybe just sort of the rough outline sketched by the CDC guidelines. To me, it's just not the key focus right now because physicians are decreasing prescribing. They have gotten the message. There is a lot of fear out there. I have medical students and PA students coming up to me and being like, should I ever prescribe these things? And I'm like, this is part of the toolbox. I mean, we still need to use them. And meanwhile, I think at least at the state legislative level, focusing on how do we find more clever ways to restrict prescribing distracts us from the real challenges in addiction treatment and the huge changes we need to make to our mental health infrastructure that I think have not been as much a part of the policy conversation as they should. The other thing I would add is I think actually it seems to have made a really profound impact when there was sort of almost an erratum of types in the New England Journal a couple weeks ago, where the authors of the CDC guideline basically said, look, if you read the guideline carefully, we never wanted patients to be tapered abruptly off their therapy. That was not our intention, and it kind of acknowledged it, sort of spoke to that concern out in the open. And I think actually just simply acknowledging patients on chronic opioid therapy and speaking more directly to it without necessary policy can have a lot of impact.
Anybody else want to take that on? Dan?
Yeah, I also would be careful. I think that the CDC guidelines were misunderstood and weaponized in some settings. So I think we do have to be careful. If you read them carefully, there's nothing at all wrong with them. It's just that they were misread, misinterpreted, and that did lead to. But that will happen. That will happen. The legislatures aren't necessarily scientists or aware of data and things like that, so they will make sort of knee-jerk policy changes that have unintended consequences. I happen to agree. I think that most providers now have gotten the message on both the acute and the chronic pain side that they have been overprescribing, that they have to be a little bit more careful. These millions of people, though, that are already on opioids with chronic pain, that's going to take us years or decades to figure out what to do for those individuals, because it's super hard to get them. They're dependent on opioids even if the opioids are not helping their pain.
Correct. Mike? Yeah.
I guess one issue I think that's relevant for policymakers and payers is workforce. So one hat I wear is I run a large component of the medical school curriculum at Michigan, and these are our best and brightest, like the people performing half an hour ago, an hour ago, and these are the people we want to engage to fix this problem going forward. And I'll just kind of anecdotally say that we don't have our best and brightest with an interest in this problem. They come in with an interest, but they go off and they become liver transplant surgeons and anesthesiologists. So I think we have a significant workforce problem around mental health and access to care that will start with engaging our youngest trainees to kind of want to fix these problems for society. And I don't think we have that now.
Amy, do you have any comment?
On the payer strategies, I think of a couple key things. I'll echo this morning's comment about eliminating the prior authorization for buprenorphine, office-based buprenorphine, which I realize is not a treatment for, about opiates for pain specifically, but it is about how to thoughtfully transition patients as soon as you can when it's clear they're at risk for adverse outcomes. Obviously, figuring out how to make sure that there's sufficient reimbursement coverage for other modalities of pain care that require different types of providers, physical therapy, things like that, yoga if possible, it would be an important component to ensuring good quality care for opioids. I think those are the key to making sure that we have a balanced approach.
Great. Monica, do we have a question from the audience?
Since the best predictor of behavior is past behavior, what can be done to prevent this from happening all over again when a new safe opioid comes on the market, since it already has happened, and providers are faced with the decision on whether to prescribe or not prescribe?
Dr. Clauw,
Go
do you
ahead.
think there will be a safe
Dan.
opiate?
I don't think that there's ever going to be a safe opioid that's the kind that we have right now, like classic sort of mu agonists. I think some of the allosteric modulators of the opioid receptor or some of the other things that are in development could be safer opioids, but opioids are by their very nature, if you're binding to that opioid receptor, it's always going to have these inherent issues, and it's a hormone system within the body that's widely distributed with receptors in all sorts of different places. So I don't think there will be a safe opioid unless it's an inherently different kind of opioid than we have right now.
And I would just say too, even those G protein coupled, some of the newer opioids that are coming out don't really show a different addictive potential. They spare patients many of the side effects, but to date, there's really no evidence that those are really going to address the potential for dependence and addiction. So yeah, Mike.
I think it's a great question. I think to try to remain kind of optimistic with this horrible epidemic, I do think there's more awareness. I'm not a pain expert, but I think among the practitioners, there's more awareness on that pills are not going to fix all the problems. So I think there will be more access to kind of non-pharmacologic therapies and more acceptance in the general medical community that these can have a big impact on patients. And surgery hurts, and opioids are not the fix. I think we've learned that lesson. So I'm guardedly optimistic that many of us have learned how to be better clinicians and how to do more kind of patient-centered care through this horrible problem.
Michael?
Yeah, I guess just one thought, kind of taking this maybe past the idea of a safe opioid, but just how do we prevent something like this from happening again more broadly? Potentially I'm being too optimistic, but I'd like to think that from the early 90s to now, we've moved, the medical community has moved towards holding expert-based medicine in much lower regard than evidence-based medicine, and that there's a much stronger demand for strong randomized controlled trial evidence that a drug does the thing that we want it to do, at least somewhat. And we didn't have that in the 90s when this kind of all got caught up. And one story I like to tell is actually, I was not in medical school that long ago. I went to Harvard Medical School, and I was taught all of the stuff that you read in these litigation complaints about pseudo-addiction, about patients in pain of an opioid deficiency, about how if someone's in pain, then they can't develop dependence because the pain is like an opioid deficient state. All of these things, I absorbed all of them. And I would like to think that the medical community has become more skeptical.
How will we know? We've seen year-over-year declines. How will we know that the pendulum has swung too far? Certainly, part of that CDC letter within the New England Journal was with at least that public outcry that's happened today, even though I don't personally believe we've swung too far. How will we know, and what are we doing to actually measure this idea that we could have a pendulum swing so far that we're back on the other side of a different problem? How will we know that?
On the chronic pain side, I'm not sure it can swing too far.
Yep.
It just needs to swing back to where it was, before the mid-90s. Where people use these last after everything else. So that, what more could or should we have learned from the last 20-some years than these are really dangerous drugs and they don't work that well. So put them back where they belong as last line therapy in people that have been refractory to everything else. But we have to set aside the people that are on chronic opioid therapy. That's an entirely different group of people. I'm talking about new starts. I'm talking about people that we're seeing newly with chronic pain. And it's like, don't go near opioids until you've tried everything else. And that's the way it used to be, and that's the way it should be again. And that the pendulum can't swing any further than that. But again, the people I worry about there probably are really millions of people with chronic pain that are on opioids, and we talk about this a lot. We've done work on it. All the reasons that they want to continue to take their opioid, very few of them have anything to do with pain control. They're taking these as anti-anxiety drugs, as hypnotics, as anti-stress drugs, and in many cases they just simply can't come off because they're totally dependent. And that, again, that's another entirely different set of strategies that we're going to need to deploy to try to very slowly, gradually. And some of those people we'll find do benefit from their opioids. They're the people that are unusual but benefit from their opioids. But you don't know that until you try to taper the person and you see that they have a worsening of pain and a worsening of functional status that is unrelated to rapid withdrawal, and that you're basically withdrawing too rapidly.
And what you describe with respect to the CDC guideline is almost aligned with what the CDC guidelines say. It's not the CDC guidelines don't say never start opioids. Right. It's just as Dr. Bohnert laid out, they put forth a pathway that says if you're going to start them, set goals, check in on patients, and assess risk and benefit. Don't just keep coming in and writing the script month over month without assessing or escalating, which is what we've done for decades. So in many ways, again, I think that despite all of the sort of backlash we've seen with CDC guidelines, they seem to be aligned with practical, rational care. Mike? And then I'll come to you, Amy.
I think it's critical that there are kind of population-based kind of portals, so to speak, for patient-reported outcomes. So we are listening to patients, and we're letting them kind of inform us how to do best care. And then it takes real science to take all of that data to systematically kind of not practice anecdotal medicine, but to use evidence. I think we have that technology now. That's a relatively new technology within health services research, and I think that will hopefully keep us moving in the right direction.
Amy, did you have a comment?
Yeah, I think it will be hard, in terms of chronic pain, it will be hard to answer that question without a better understanding, a scientific basis of which patients are benefiting from opioids or likely to benefit from opioids based on their pain condition, other personal characteristics. And I'm not sure that there's much will to fund the kind of research that'll answer that question in the context of how much more emphasis there is on harms rather than benefits. So I think about that. The place where I've been worrying more about the pendulum swinging too far is the unintended consequences on patients with cancer. Yeah. I was speaking to a colleague who's an oncologist in the VA yesterday, and she said with the levels of regulatory burden to prescribe opioids based on all the different policies, even though there's pretty universal agreement that patients with cancer, and particularly metastatic cancer, that opioid use is fully appropriate, it takes 45 minutes per patient to prescribe an opioid, and whether that's for their acute post-surgical care or for end-of-life opioid use. And I don't think we've quite figured out how to make nuanced policies that don't inadvertently discourage patients or providers from prescribing opiates to patients where it's completely appropriate.
That's a fair comment. We have another question for the audience.
When comparing the number of opioid prescriptions before and after the release of the CDC guidelines, what data sets are being used?
For the analysis I described, we used the Equivia data set, which is used to be called M.H.S. It's national data of, I think it covers something like 90% of pharmacies in the country that's captured when those prescriptions are filled. So we don't know the number of prescriptions being written, which I think is an interesting question too. You've been looking at, you reported data from Medicaid, correct?
Yeah, Medicare and private insurance claims.
Yeah.
And I guess just one, since if it's a data question, this is the kind of thing I love to answer. But two contrasts are that there are data sets where you can look at overall prescribing, and there are data sets where you can do a better job of following patients longitudinally over time and actually having information about those patients. Mm-hmm. And those are two different questions. One is just what is the pharmaceutical market and medical community doing overall. The other is isolating vulnerable patient populations and understanding how they're being cared for. So the data that's being used does have important implications for the questions you can ask.
Another question.
With pain being subjective, how should doctors be diagnosing and treating pain moving forward? And additionally, is there training around complex trauma and how this may manifest as physical pain?
It's a nice one too, Monica.
Yeah.
Dan, do you want to take on the first question?
Yeah, there are a lot of medical conditions where the symptoms are entirely subjective, and it's not clear to me why pain always gets sort of called out in that regard. Almost all psychiatric disorders, neurologic disorders are really symptom-based and symptom-driven, and for a lot of those conditions, we don't have any better objective marker than we do with chronic pain patients. So, it's always been odd to me that it's like, but I think a lot of that harkens back. In medical school, a lot of us are told that there's a lot of people faking their pain, and that you have to watch out for those people, and that they're malingering, and again, over the course of my career, the number of people that I, have presented themselves to me as a chronic pain patient that I figured out were faking is exceedingly low. Now, maybe they kept fooling me, but I don't think so. I think that it's actually, we should just stop teaching people that, because it puts this inherent distrust that you can't believe what the patient is telling you. And I think that you should always start out with the supposition that the patient's telling you the truth, unless and until they do something to declare that they're not telling the truth. But I think with pain, it's almost like we trained a couple generations of people to do the converse, and to not believe it because we couldn't see it or we couldn't measure it.
Yeah. Go ahead.
I was going to briefly speak to the trauma question. As a primary care physician, it's actually really stunning to me to see how common childhood trauma is, either sexual abuse or physical abuse or other types of violence. And I think that I'm finding more and more in primary care that kind of managing the after effects of trauma is one of the kind of most challenging and most common issues that I'm like the least prepared to manage. And I think that's an issue the whole medical community needs to manage, actually. And I'm very lucky to work with some social workers who are actually very well versed in trauma-informed therapy. But it's something that I think I feel like it only becomes more and more important every day.
Yeah, I can't agree more. We have a postdoctoral fellow, Jen Pierce, who's doing some innovative work around trauma and pain. I really think this is a piece of untangling. And again, when we talk about policy and practice, any policymakers or payers out there really thinking about access to treatment after these traumas, and really thinking about making this type of care immediately available, because it's really important. Dan?
I think one of the other opportunities we have, and we're doing a lot of research on this now, is changing the scope of practice of different providers and training more providers to do behavioral interventions. Virtually any provider really could be learning how to do, sort of cognitive behavioral therapy and, lighter, not maybe deep trauma-based therapy, but in the, these studies we have ongoing, where we even have medical assistants, giving brief cognitive and behavioral interventions in the pain clinic. So I think that one of the opportunities we'll have as we really move into this model where we're trying to deliver this interdisciplinary care, integrative care with a lot of the non-pharmacologic therapies, will be to try to modify the scope of practice of OTs, PTs, pharmacists, and get them to, because they are in the right places in our health system, get them to be part of these teams that can help improve the care of individuals with chronic pain.
Great. I want to wrap up, but I want to give each of you an opportunity just to give a final thought. And Mike, since I work with you the most, I'm going to put it right back to you.
Sure. Well, one, it's an honor to be here and work with you, Chad. I guess my final thought is that all physicians and nurses in the audience, I kind of feel that we should feel responsible largely for this epidemic. I don't really buy the pharma argument. The bottom line is I wrote those scripts, and I need to change my practice, and that's I guess how we need to move forward.
Your mic's cutting out.
I would finish with, so I talked mostly on improving opiate prescribing, and I think we're moving in the right direction with that, and I'm really concerned about what we can do to improve the quality and access to medications for opioid use disorders, as well as explore other medications that could be developed. Having only 3 treatments for this condition is really insufficient for having patient-centered options.
All I have to say is we can do better, we need to do better. We don't need, it would be great if we had effective new analgesics, but if we just use the current treatments that we have for chronic pain in the right way, we could do infinitely better than we do right now. And a big part is changing the reimbursement models to get the non-pharm and the behavioral interventions where they're needed.
Great. I guess from my side, this is kind of going back to the pendulum question, which is I'm finding among trainees and residents it's really important to just appreciate, to have an understanding of the evidence behind the different pain treatments that we use. And I think now it's clear that actually, opioids do treat pain, but they're just not special. Like they aren't particularly powerful pain medications. They really don't outperform ibuprofen, sometimes even Tylenol. The placebo effect can be equivalently as efficacious as opioids. But it doesn't mean they don't have a role. It's just that there are certain patient populations, for instance, those who have kidney disease or those who've had a prior adverse reaction to therapies like ibuprofen. And so I think just understanding kind of where each of these therapies fits in the toolbox is something that we need to continue to teach, and not just fear that if you prescribe these medications the wrong way, something terrible will happen.
Join me in thanking this terrific panel for their presentation.